This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I'm still your host, Dr. Tony Tarchichi. If you're new here, welcome, and then if you've been here before, welcome back. We are a continuing medical education podcast geared towards pediatric hospitalists and all those who take care of kids in the hospital. We have been going since October of 2016, coming to you with different topics from the American Board of Pediatric Content Specifications for PHM and different things that pop up interestingly throughout our time. COVID's a most common example, but other things have come up. And this is one of those topics. I'm very excited about our topic today. Before we start, shout out to University of Pittsburgh for sponsoring the CME for this. So if you want CME for this podcast, just click on the link and you'll answer some questions, and it's free CME from them. So thank you. And we're going to give a quick shout out to Dr. Dennis Simon for helping put this together at the Children's Hospital of Pittsburgh. So thanks, Dr. Simon. And then, as you know, if you are practicing pediatrics in inpatient setting in any way, this past year has been busy, hectic, and a little bit odd, right? July to December of 2022 has seen some of the highest censuses I've ever been a part of. Multiple children's hospitals almost called in the National Guard, had to take steps to increase their ability to take care of kids because of the volume. We had this triple-demic, people are calling it, huge RSV, lots of flu, other viruses as well. COVID was still around. And if you're practicing, one of the things you have noticed is more than ever, we are seeing the usage of albuterol for bronchiolitis, even RSV bronchiolitis. And traditionally we're taught on the pediatric floors that it's not helpful or doesn't change any length of stay or anything. But our ICU colleagues and our emergency department colleagues are using it more and more. So it brought up the interesting question, why? What's going on? And let's talk about it. So that's what we're going to do here today. And we have an expert guest who has experience on this topic. So without further ado, let me introduce our expert guest and we'll start chatting. Dr. Jonathan Pelletier is our distinguished guest today. He's a pediatric intensivist and data scientist at Akron Children's Hospital and an assistant professor of pediatrics at Northeast Ohio Medical University. He received his BS in microbiology from the University of Maine and his medical doctorate at Tufts University School of Medicine. He completed pediatric residency at Duke University Medical Center. He completed pediatric critical care fellowship right here at UPMC Children's Hospital of Pittsburgh and a T32 postdoctoral fellowship through the Safari Center for Resuscitation Research. His research seeks to harmonize multi-center databases with granular EHR data to improve bedside clinical decision support, particularly as it pertains to respiratory failure. He's published several articles describing healthcare utilization for children with bronchiolitis and is especially interested in the impact of COVID-19 pandemic on respiratory pathogen transmission. So, Dr. Pelletier, thank you for joining us and being a part of this.
Thanks for having me, Tony. The past year's been wild, and it's been really fun and busy to track it both from the epidemiologic side and from the clinical side.
Well, I agree. Now, before we get further, John, let's do our disclosures because we are a CME podcast. I will go first, and then I will kick it out to you. I was for the Sanofi company. I was on the 2022 meningococcal vaccine immunocompromised advisory board, which should have no bearing on what we're talking about today.
Thank you. And I have no external disclosures, although I should disclose that about 30% of my time is sponsored by Akron Children's Hospital as a data scientist and physician informaticist.
All right. So now, John, you heard the intro. Basically, the ICU is using more of albuterol for this bronchiolitis. On the PHM side, we're not using it more. So let's talk about what's going on.
Yeah. So I think it's important to take a step back and say what's going on with bronchiolitis, period, which hopefully can help inform our discussion about what's happening with albuterol in bronchiolitis specifically. So, as you know, the COVID-19 pandemic really disrupted the normal seasonal viral transmission that we're used to seeing. For the last 30 years that we've been tracking this, bronchiolitis follows a reliable winter predominant seasonal pattern. And we always know, or at least we knew up until COVID, that we would start seeing it in November in the southern or in southeastern United States. It would migrate northward. And then where you and I practice in the Midwest, we would really start to get quite busy with it in December and January. That's really changed over the past couple of years, particularly with the impact of masking and social distancing on bronchiolitis. Now, I think everyone's aware acutely of how much the seasonal patterns have changed. One, because we saw a summertime peak in 2021, which we had never seen before. And two, because we saw an early seasonal peak this year in 2022 slash 2023. However, the other thing that is important to note in bronchiolitis hospitalization, specifically in the 2021-22 seasons and in the 2022-23 seasons, is that the children we're admitting with RSV tend to be, on average, older than children that we had admitted before the pandemic, and that they, probably as a result of being older, on average, seem to be less likely to receive invasive mechanical ventilation than in the years before the pandemic. So to sort of summarize all of that, in addition to seeing RSV at weird seasonal times or atypical seasonal times, we're also seeing a little bit of a different patient population being admitted, at least to the ICU, than we were before the pandemic. Does that reflect in your experience on the wards as well, Tony? I have to admit that both statistically as well as in the ICU, I'm seeing a lot more children between 12 and 24 months, and even a couple of 2-year-olds admitted for bronchiolitis that I wasn't used to seeing before.
Yeah, I agree 100% what you're saying. We've seen older kids. I've even seen 3 and 4-year-olds coming in with RSV and having significant respiratory distress, looking like bronchiolitis, exactly like it. And we call it viral pneumonia, but I mean, it looks exceedingly similar. So it's been older than I've normally seen and at much higher volumes and all throughout the year. And the ICUs, I mean, it was famous around the country, right? Because news stations were keeping track of where the free beds are because there were so few free beds for ICU beds in pediatric hospitals.
Yeah, gosh, that jives with my lived experience. More than once, I got calls from emergency department doctors asking to send me a patient from hundreds of miles away and apologizing, saying I was the 4th or 5th pediatric ICU they had called.
Yeah.
So I'm glad to hear that we have sort of similar epidemiological experiences over the past couple of years, because I think it can help inform some of the discussion that I think you really want to have, which is, are we using more ancillary therapies, albuterol, corticosteroids, and racemic epinephrine than we've used before? And if so, why? So I thought it would be helpful to kind of jump into, as a starting point or as a frame of reference, the AAP policy statement on the management of bronchiolitis, and look at some of the underlying principal evidence, both the Cochrane reviews as well as the primary studies that informed those recommendations, and then consider how they might or might not apply as well to the patient population that we're seeing now. Does that seem reasonable to you?
It's a good way to start. I like that.
Okay. So, I want to be clear and upfront whenever we talk about therapeutics for bronchiolitis, that there is an American Academy of Pediatrics clinical practice guideline that generally says how we should manage these patients, at least while they're inpatients and on the floor. The last iteration of that guideline was published in 2014 by Dr. Ralston and colleagues, and you can find that reference both in Pediatrics, and I'm sure it'll be in the show notes today. So to briefly summarize sort of the key action statements from the AAP on bronchiolitis, I suspect a lot of the audience knows here, right? But the AAP says that for inpatients admitted with bronchiolitis, that we should not routinely use albuterol. We should not routinely use racemic epinephrine or inhaled epinephrine, depending on your hospital formulary, and we should not routinely use corticosteroids. There are, in my mind, a couple of key caveat statements that are made in the guidelines that the AAP put out back in 2014. And sort of the key ones that I'd like to highlight are, number one, the AAP gives me a pass. So they do specifically say that they don't apply their guidelines to critically ill infants. So I do think I get a little bit more leeway to violate at least the letter of the law on those guidelines, if not the spirit of the law. Thing two is that in the evidence summaries for the AAP guidelines, they explicitly note that when they performed the literature search to inform the guidelines, that they were looking at evidence for children with a first episode of bronchiolitis and not with a history of recurrent wheezing or a known atopic history. And both the Cochrane reviews and the primary studies that they elect to present in those guidelines reflect that selection criteria. So children with a history of recurrent wheezing, that 12-month-old, 15-month-old, or as you were saying, even maybe, a 2, 3, 4-year-old who's presenting with RSV on their fourth episode of viral-induced wheezing are specifically excluded from the evidence base that's used to inform the guidelines. And so I think that combined with the epidemiologic changes that we briefly highlighted at the beginning of the show are going to inform a little bit about our conversation specifically around bronchiolitis and the use of albuterol and or steroids. And then lastly is that when the AAP chose its target outcomes on which they judged therapies, they were very explicit in that they chose hard markers, which what I mean by that are precisely quantifiable markers such as inpatient hospital length of stay, or proportion of patients admitted from the emergency department. And they deliberately chose to exclude studies looking at severity of illness scores for bronchiolitis. Now, I don't think that was a bad choice. And the reason I don't is because we don't have a well-performing clinical severity score for bronchiolitis. I do think that most pediatric hospitals around the country use some version of a bronchiolitis severity score that combines vital signs with physical examination components to try and put a number on how sick is this kid. But it's worth noting, we don't have any validated scores for bronchiolitis that predict the need for intensive care or that predict the need for mechanical ventilation or admission or hospital length of stay. So the reason the AAP chose not to include improvement in clinical severity scores was that they felt like those scores couldn't be well validated. Oh, sorry, I can pause. I'm sure you have some comments before we go any further.
No, I mean, I agree with everything you're saying so far. We've looked at albuterol and bronchiolitis in the past on the podcast and talked about how in Europe and in Australia and Canada, they even differ from us in that they feel bronchiolitis is only within the first year. From 1 to 2 years, they feel must be asthma related. So there's always been a little bit of a difference. And you're right, for the older kids, if there's recurrent wheezing, if there is atopic history in the family, we're more likely to see albuterol being used in those kids. And you're right about the guidelines. I mean, I don't have anything more. The AAP does give you all a pass. We've talked about their hard markers in the past. And it is interesting that we don't have a really good validated bronchiolitis severity score index to use nationally. I think this will be the beginning of a theme in this podcast, which is there's not as much data as we'd like there to be in something that is seen so regularly. Would you agree with that?
Oh, gosh. I will tell you, in some ways, Tony, I really think a well-performing, validated, and replicable clinical severity score for bronchiolitis that could actually predict ICU utilization or accurately predict invasive mechanical ventilation would be like the holy grail of bronchiolitis researchers. When I've done informatics projects looking at things like predicting failure rates for high flow nasal cannula and bronchiolitis, or predicting need for invasive mechanical ventilation, or even trying to predict which children in our emergency department are going to come see me in the ICU, it is frustrating. We just don't have any great markers that really seem to capture this patient population well. And I think that's really for two reasons. Reason one is that this is, in my opinion, a really heterogeneous group of patients. I don't think every child with bronchiolitis has the same disease, even if they have the same virus. And reason number two, we all know these kids are dynamic, right? We've all been unfortunate enough to respond to a code blue on the floor for a child in severe respiratory distress who winds up, getting rapidly intubated, and had the experience of saying, gosh, I saw this patient personally 2 hours ago, and I'm here to tell you they didn't look like that. So I wish that I could better predict which one of these kids is going to get sick, but so far, at least, I can't.
Or the reverse of that, where we call the ICU because a patient on the floor looks sick. By the time they come down, and it's not very long, the kid looks much better, and we've done nothing. And so it's a really dynamic, quickly changing disease.
On my side of the aisle, we call that a therapeutic ICU trip.
Yeah.
All right. So that all being said, let's try and jump into the data. So I do think on average you are probably right. And the reason I say you're probably right is because I don't yet have, I hope to have by a little bit later this year, but I don't yet have hard numbers for you on what proportion of children, both admitted to the hospital and admitted to the intensive care unit, are receiving albuterol nationally. That's data I'm working on obtaining, and some of the data I'm hoping to share this upcoming spring at pediatric academic societies. But I do have data for you saying that our trends before the pandemic in terms of ICU utilization have held up. So we continue to transfer a higher proportion of our children with bronchiolitis to the ICU post-pandemic than we historically had back in the early 2010s. And interestingly, during the pandemic, again, my suspicion is probably because this is age-related, we are finally starting to see some improvement or decreases in the invasive mechanical ventilation rates for those children. Now, my anecdotal experience is that I think I probably use more albuterol in this patient population than I did a few years ago, but I can't prove that to you. So I think if we're going to do the rest of this discussion about the data specifically surrounding albuterol, steroids, and racemic epinephrine, we're going to have to take it on faith that our own anecdotal experience that this is happening more is a valid assumption. Are you willing to do that?
I am. I think that's a fair assumption.
Okay. So, with that being said, I think then it's worthwhile jumping into the question of which I think is really the meat of it here is, gosh, John, it seems like you and fellow intensivists are using more ancillary therapies. And again, to be clear, what I mean is albuterol, racemic, and corticosteroids than we historically used to, even 5 or 10 years ago. Why is that true? Is there any particular rhyme or reason to it? And does it work, or are we just driving expense and driving down care efficiency? Because bronchiolitis is a common condition. So if we're doing things that are expensive and not helpful, even if it's only $20 a patient over several 100,000 patients, that really adds up. Yeah. So let's kind of jump into the data then on the original source data that helped inform the guidelines for the use of ancillary therapies or the non-use of ancillary therapies in bronchiolitis. I think if it's okay with you, I'd like to start with albuterol. And the reason I'd like to is because I don't, in my mind at least, it's hard for me to think about wanting to use corticosteroids in a patient with bronchiolitis unless I personally have seen a response to albuterol. Are you okay starting with that?
I think that's fair.
Cool. So again, to be clear and fair, the AAP says that at least for children on the floor, we should not routinely do this, right? So we should not routinely use albuterol or salbutamol for infants and children with the diagnosis of bronchiolitis. And they give us a grade B quality recommendation, or a grade B quality evidence, and said that that was a strong recommendation. So if you look at the Cochrane review that sort of formed the thrust of the argument there that the AAP had, there was a Cochrane review, and I hope I'm pronouncing their name correctly, but by Dr. Gadomski, that analyzed infants in less than 24 months old that had bronchiolitis, and they included all long and short-acting bronchodilators. Now, in that Cochrane review, the primary outcome was actually oxygen saturation. So the primary question being asked by the investigators was, does albuterol usage improve oxygen saturation in infants and children with bronchiolitis? I personally take a little bit of issue with their chosen primary outcome there, only because when I think about my targeted therapeutic endpoint when I administer albuterol for bronchiolitis, but truthfully also for asthma, I very rarely think of albuterol as a drug that improves VQ mismatching and raises oxygen saturation. So I wouldn't have expected that to be a positive study. That being said, they did include several what I think are key secondary outcomes, or important secondary outcomes, where I think that the data is helpful. So important secondary outcomes considered in that Cochrane review were improvements in clinical severity score, hospital admission proportion for children in the emergency department, and length of stay for children who were already admitted to the hospital. So what they found, and again, to be clear, because their primary outcome was oxygen saturation, that was their conclusion was that there was no significant improvement in oxygen saturation across all the studies that they analyzed in the Cochrane review. Again, when I think about the use of albuterol in this case, that's not really the therapeutic endpoint I'm after. So when I looked at what were, for me, some of the more interesting secondary outcomes here, one of the ones was, is there an improvement in clinical severity score for patients with bronchiolitis when we treat them with bronchodilators? And what they found in their review of 7 trials, with a total N of only 365 patients. So again, even when you put these 7 trials together, they're still pretty small. But what they found was that about 64% of infants treated with bronchodilators improved, compared to only 27% that were treated with placebo. And so that gave them, the way that they performed the statistical analysis was actually to have an odds ratio for no improvement. So in this case, less than 1 is better. And what they found was that the odds ratio for no improvement was 0.18, with a 95% confidence interval of 0.06 to 0.5. And so I would conclude, based on that study, or based on that analysis, that bronchiolitis improves the clinical state of these patients, even if it's only transient, compared to placebo use. Now, it's important to note 2 things here. One is that the AAP does not consider this level of evidence when they build the guidelines. And again, the rationale for that is that clinical scores for bronchiolitis have not been shown to reliably predict other markers of goodness, aka duration of illness, hospital length of stay, or other markers of badness, aka ICU admission, need for mechanical ventilation, or even mortality. So when I think about this data, assuming that this is real, and I think when I think about this data, I think to myself, this effect is probably real based on my lived clinical experience and based on the statistical analysis I'm seeing. It does seem to me like like albuterol improves the clinical state of at least some subpopulation of children with bronchiolitis, and at least transiently. So then the follow-up question I have to ask myself is, okay, well, if it improves the clinical score of some subpopulation of children with bronchiolitis, but probably not all, and if it improves their clinical state only transiently, is that improvement important, clinically important, yes or no? And if the answer to that question is yes, then the follow-up question is, okay, but which patients with bronchiolitis is it most likely to work for? Would you be willing to agree that those are at least important questions to ask if this data is real?
Yeah, if the data is real, does it matter? Does it reduce anything else, such as length of stay or anything else we've talked about? Is it very transient, or is it meaningfully transient, for lack of a better term? And then if it's meaningfully transient, whom is it meaningfully transient on? Does it matter? Because I have seen preliminary studies where it may matter of the organism, so RSV versus non-RSV, or perhaps the person. So whom? How do we figure that out? I agree with you. Those are important questions.
Okay. And I want to be perfectly clear here, particularly because you mentioned things like length of stay. I do not have any data except for one randomized clinical trial that included the combination of epinephrine and, racemic epinephrine and dexamethasone, that there could potentially be an improvement in length of stay. So I want to be upfront with your audience here that I am not arguing that treating a bronchiolytic with albuterol is going to get them out of the hospital faster. I think the only argument I can make here is that it might make them look better, at least transiently. And I think that, in my mind, is also in keeping with what I'm expecting out of the physiology of this drug. There's no reason to think that albuterol is going to help a child clear RSV faster. I guess, for the sake of argument, that's also true of the commonly applied therapeutics for RSV, like oxygen and IV fluids. Those don't actually make the child better any faster, right? They just help them to live through the illness. So that's the way I think of albuterol as well. So then, when I ask myself the question of, okay, it seems like albuterol at least might transiently improve the clinical status of some children with bronchiolitis. Question one is, well, do I care? Is that important? Is the improvement meaningful enough to make a difference? And I think this probably depends a lot on your practice setting. So, and the baseline degree of severity of illness of the child. And I think this is probably why you see this drug being used much more frequently among sicker children. So what we know about albuterol, and I think by correlation, corticosteroids, is that there's a much higher probability of a child being prescribed these drugs if they're in an emergency or ICU setting than if they're in a pediatric ward setting. And I think that really drives at the answer to question number one here, which is, if this only makes my kid a little better for a little bit of time, is it worth it at all, even if that's real? And I would tell you that if this is a mildly ill bronchiolytic on 1 liter, nasal cannula oxygen, eating well, looking well, with relatively normal vital signs and just a little bit of wheezing, then the answer to that question is probably not, right? And I think this is, in my mind, I think this probably gets at some of, I don't want to presuppose my ideas or project my ideas onto anyone at the AAP, but if I had to take a stab at it, I think this probably informs some of the AAP guidelines on this topic, right? Like, if a child is not that sick, and even if giving them albuterol makes them a little better for a little while, well, it probably just doesn't matter, right? Like, if the difference is the child is more or less wheezy, but not tremendously different in terms of their degree of respiratory distress and not different in terms of how long they're going to be in the hospital, well, then that outcome probably doesn't matter at all. And if that's really true, probably best to save the expense, the expense and likely side effects of the drug. But in the setting where I work, I'm often looking at or confronted by patients who are edge cases, right? Patients who I frequently have on some form of non-invasive support, whether that's high-flow nasal cannula or non-invasive CPAP or BiPAP therapy, and am trying to avoid invasive mechanical ventilation and a lot of the attendant harm that comes with that, both in terms of pulmonary barotrauma from my ventilator, as well as the neuroapoptosis that comes with the sedatives that I'm going to have to use to keep them safely on the vent for the next 5 days. So in my mind, if I'm looking at a child in the ICU and I think to myself, this child is on the edge of needing an escalation in therapy, either needing to be escalated from modalities of non-invasive support, or in probably the most important case, on the edge of what I can support with non-invasive therapies and trying to avoid invasive mechanical ventilation, then I would tell you, I think the risk-benefit ratio changes. If I can make that patient look a little better with the addition of a new therapy, and avoid invasive mechanical ventilation, I think that there's both a lot of clinical benefit for that child and also a lot of benefit for the healthcare system in terms of avoiding a stay that with invasive mechanical ventilation, which almost instantaneously quintuples the cost of admission for that family. Would you be willing to agree with that?
I couldn't agree more. And when we were preparing for this episode, I started looking for data to support that because it makes sense that that's the ICU reasoning, right? If you're trying to avoid intubating a child, and this at least makes the kid look better for a short period of time, and you can avoid intubating a child, it makes logical sense. But I couldn't find any data for that. That was some of the frustrating part is it makes logical sense, but there's nothing supporting it. The little data I found for albuterol use in young infants hospitalized with acute RSV bronchiolitis from Interdisciplinary Perspective Infectious Disease in 2012 included some ICU patients, not a majority of the patients that they enrolled, and it showed that albuterol increased length of stay, but it was a small study. There is a small study I found where in an ICU where children were intubated and albuterol improved some of the mechanics of ventilation that I didn't necessarily understand a little bit faster. But there wasn't anything. So to answer your question, frankly, because then the other side of that is when you in the ICU will use albuterol and use steroids, and the patient comes out to me, and then I immediately stop them, and the child continues to improve, the natural question is, well, did the child ever need it? But if the reasoning is the child was critically ill and we're trying to avoid invasive mechanical ventilation and all things that go along with it, it does make sense. But there's neither good nor bad data to support that, as far as I know, and you would know better than I would.
Sure. So I'm going to be upfront here, and I would tell you, I think the best data I have to support this is bad data, but I'll give you what I have.
Okay.
Because I also think that at the end of the day, part of the reason you continue to see intensivists use this is that their lived bedside clinical experience supports its use. And unfortunately, in my opinion, that just has not been well captured in clinical trials. But let me offer you what data that at least that I could find that's out there to support this practice. So one, I do think it's really important to say, hey, the one Cochrane review we have on this topic, that's probably the best data. Those are predominantly floor level patients, but it does support that 2/3 of patients get better being treated with albuterol as opposed to 27% with placebo, which in this case is essentially nebulized normal saline, which also probably has benefits in terms of secretion clearance, mucus plugging, those kinds of things. So I think that's probably the strongest level of evidence, but you're totally right that it's not specific to the critically ill population. There is one other study that I think is important when we think about the specific use of albuterol and or racemic epinephrine to improve clinical scores. So one is I'm just pulling the exact reference because I want to make sure that I quote it precisely. So one is the 2008 study. Again, I hope I'm pronouncing the name correctly, but by Karadag et al. That was in the journal Respiration and International Review of Thoracic Diseases. So this was a double-blinded RCT that included 69 hospital infants that had moderate to severe bronchiolitis, and they were randomized here to either salbutamol, ipratropium bromide, or placebo. And here, the reason I like this trial is because they're actually following the clinical outcome that I care about. So they were looking at improvement at clinical scores compared to baseline at half an hour, 8 hours, 24, and 48 hours after treatment with each of those therapies. And what they found was that there was significant and sustained improvement, statistically significant, I should say, clinically significant, again, is in the eye of the beholder, but at least statistically significant and sustained improvement in the clinical scores of patients receiving both albuterol and ipratropium bromide at all time intervals, half an hour, 8 hours, 24 hours. It was not true anymore at 48 hours, although I should say the clinical score of all the infants was substantially better at 48 hours than at baseline. And so, again, that's not specific to the ICU population, but when we think of moderate to severe bronchiolitis, I think to myself, okay, that's a population that somewhat resembles at least the population that I take care of, who I would describe as mostly having severe or critical bronchiolitis. And then the other single study that I do have that is really ICU specific is there was a randomized controlled trial of bronchodilators that was performed in the ICU setting for children undergoing invasive mechanical ventilation for bronchiolitis. This is a really small study. It was published in Pediatric Critical Care Medicine in 2008, and it was by Dr. Levin et al. And this was actually looking at objective measurements of respiratory mechanics in children treated with either albuterol, the L enantiomer of albuterol. Gosh, Tony, I'm so sorry. I don't know if I'm allowed to use brand names on the show or not.
You can.
Oh, okay. So the L enantiomer of albuterol that we sometimes call Xopenex, or racemic epinephrine, specific to children undergoing invasive mechanical ventilation for bronchiolitis. And this in my mind is probably, while being the smallest study, is probably one of the best scientific grades of evidence, though despite a very low number of patients, because they had objective markers of airway resistance. And so what they did is a handy feature of having somebody intubated is that it's basically a free minute-by-minute pulmonary function test. We have the ability to perform maneuvers on the ventilator, which can calculate airways resistance and lung compliance minute by minute. And it's actually pretty easy to do in the ICU. And I would say we do this pretty often, multiple times a day, usually for intubated patients, at least patients intubated for primary lung disease. Anyway, what they found was that after treatment with any of the above, so albuterol, L-albuterol, or racemic epinephrine, there was on average a 15 to 20% reduction in airway resistance among those patients compared to before the study. Again, they used nebulized normal saline as their placebo, and I will say that they saw some improvement in airway resistance in the placebo group as well, probably reflecting that some of the airway resistance we see in bronchiolitis is due to secretions and mucus plugging. We all know that. And inhaled therapies allow us to reduce secretions and mucus plugging. That said, the difference was greater in all of the drug groups, albuterol, L-albuterol, and racemic epinephrine compared to placebo, and it was greatest in regular old albuterol, which also is convenient because it's a generic, very inexpensive drug to give.
Important. Can I ask a question on that
Please,
study?
Absolutely.
Were they able to get those kids off of that pressure support faster in the albuterol or Xopenex or racemic epi groups?
That's such a great question. And I wish I had the answer to that. The short answer to that is not in a way that we would consider statistically significant. The long answer to that is not what this trial was powered to do. This was a tiny study. It was only 22 infants in the entire study population. They were able to get away with such a small sample size because, again, measurements are pretty precise. When you're just looking at minute by minute ventilator mechanics. But this was not a study that in any way would offer us a reasonably powered assessment of does that decrease the duration of invasive mechanical ventilation.
It's interesting you bring that up because there was a study that we looked at for this recording, Journal of Pediatrics 2022, pragmatic randomized trial of corticosteroids and inhaled epinephrine for bronchiolitis in children in intensive care by Ben Gelbert, Brent McSherry et al., our colleagues in Australia, who we've often referenced, who've done such great work. This was a 210 children study from 2013 to 2019, pragmatic, multi-center, open-label, randomized trial where they looked at those who got steroids and racemic epi and those who did not. And what they found is in the corticosteroid racemic epi group, more kids were able to get off pressure support faster. And so when I began doing research for this podcast, I saw more evidence for inhaled racemic epi and steroids than albuterol and steroids. And I wonder if in the ICU community, if you're starting to see the same thing, if we may start seeing more inhaled racemic epinephrine and steroids for bronchiolitis.
So gosh, Tony, it's so interesting that you do bring up the specific question of the combination of steroids and racemic epinephrine, because there was another study that was conducted by Dr. Plint et al. In the New England Journal of Medicine in 2009. They had a randomized controlled trial, a multi-center trial, looking at 800 infants presenting to the emergency department with bronchiolitis. So different patient population, not quite as sick because it's all comers in the ED, and not patients receiving ventilatory support necessarily. And they did a multifactorial design looking at placebo, dexamethasone, racemic epinephrine, or the combination of racemic epinephrine and dexamethasone, looking at a primary outcome of the proportion of children who would need to be admitted to the emergency department within 7 days. And what they found, interestingly, was that there was a statistically significant reduction in the proportion of children admitted to the ED within 7 days, but only in the combination of dexamethasone and racemic epinephrine. And it's important to note that while that finding in unadjusted analyses was strongly statistically significant, the p-value did just exceed 0.05 when they adjusted for the four-way multiple comparison. So in my mind, that's sort of a quasi-positive study about that. The hesitancy that I personally have had with racemic epinephrine is, while we've had now a couple of studies suggesting that there's potentially a decrease in duration of respiratory support or in the proportion of admitted patients, is that the studies looking at clinical scores have sort of been all over the place in terms of whether or not racemic epinephrine improves clinical score compared to albuterol or compared to placebo alone. So overall, the largest two randomized control trials in my mind, sort of trying to get at clinical scoring after the administration of racemic epinephrine. There was one done by Dr. Patel in the Journal of Pediatrics in 2002 that randomized kids to receive epinephrine, albuterol, or placebo with an outcome of hospital length of stay in a double-blinded fashion. And one of the things that bothered me a little bit about that study was that they didn't find any difference in their respiratory severity scores. They used the respiratory distress instrument score. And then the other study by Dr. Wainwright et al., also in the New England Journal of Medicine back in 2003, that was 194 infants that were hospitalized with bronchiolitis. And there, again, their primary outcome was clinical scoring at 30 and 60 minutes after treatment. And also co-primary outcome measures of hospital length of stay or time to discharge readiness. And in the Wainwright study, they also did not find any difference in clinical scoring. And in that study, they did not find any difference in hospital length of stay. So one of the things that I have struggled a little bit to wrap my head around in the evidence database or in the evidence sort of synopsis here is we have had a couple of promising clinical trials looking at the combination of racemic epinephrine and steroids to reduce length of stay. But it's been hard for me to understand why that might be true if we're not seeing improvement in clinical scores after the drug is given. By contrast, the studies on albuterol or albuterol and steroids have largely not shown improvements in hospital length of stay or time to discharge readiness, but have, in my opinion, overall shown a more consistent trend towards benefit in clinical scoring. And so then I guess the question, again, depends both on your practice setting and your goals of therapy. It's hard for me to make sense of the idea that a treatment like albuterol or racemic epinephrine could really impact the length of stay for these kids, because I just can't imagine that they help these infants to clear RSV or human metapneumo or whatever the underlying virus is more faster. I think of these drugs as being primarily supportive. I'd love to be wrong about that. I'm just struggling a little bit to understand the underlying physiology of why these might actually meaningfully reduce length of stay.
I agree with everything you said. I can't imagine they help clear the virus at all. And in the way the ICU people are using them, you all are more supportive, and what it sounds like more to prevent mechanical ventilation or more significant invasive procedures, which would make sense to me. It also makes sense why we stop it and things continue, because you're still going to clear the RSV. Interestingly, along the lines of, when I was talking to ICU colleagues about this in the past, they would say albuterol is a pretty safe medication. And it struck me because we always worry about tachyphylaxis, etc. And so then I started for this episode looking at, well, what do we know are the negative side effects of albuterol in pediatrics, which is a different animal, especially in infants, because as we know, most of our kids with bronchiolitis are going to be in the younger group. And I talked to our clinical pharmacist here, who's outstanding, and we did a huge data search looking. The end result is there wasn't a lot of data. There's a ton saying that it causes tachycardia, which anyone who's ever used it personally or on patients will know. We found one case report on SVT for one patient one time, and then the bulk of the negative data is in adults by far and wide. And I'm wondering if you all had the same experience.
Oh, gosh. I think you'd be hard-pressed to find an ICU physician who doesn't think albuterol causes tachycardia. And again, I think just as you framed it, we've kind of had a big discussion here about what's our goal therapeutic effect here of either albuterol, racemic, or other drugs. So then the question is, well, what are the off-target effects, and what's the frequency of those effects, and how clinically meaningful are those effects when they occur? So I think from my own lived clinical experience, I would tell you, I think that the number needed to harm to cause tachycardia from albuterol has got to be 1 or close to it. I can't imagine, or I can't remember the last child that I gave a meaningful dose of albuterol to in whom I saw no change in the heart rate. Usually, when that happens, I think to myself, oh boy, this child is not ventilating and that albuterol is not getting to the alveoli. And that's usually the time when I'm reaching for terbutaline in a severe asthmatic. But I tend to agree with you. When we look at what are the harms of using these therapies, or at least the potential harms of using these therapies. So, the side effects that the AAP cites as the reason that we shouldn't administer these drugs are tachycardia, jitteriness, and tremulousness, all of which I think are true. But if you asked me, are any of those clinically meaningful? I would tend to tell you, I think probably not for most children. There's a theoretical risk whenever we give a non-specific vasodilator of causing coronary stress, but most children tolerate tachycardia quite well, assuming that they have underlying normal cardiac anatomy and physiology. Outside of, maybe an 11-year-old asthmatic who is also a survivor of Kawasaki's and has abnormal coronary arteries, it's pretty rare for us to see coronary arteriopathy in a pediatric population. Now, I would be a little reticent to use a high dosing of albuterol in a patient with a severe underlying cardiomyopathy, or patients who have single ventricle physiology, or patients in whom I have a reason to believe that they have severe diastolic dysfunction and are going to be filling time dependent. But I just can't remember the last time I saw a child have an otherwise well child have a clinically meaningful tachycardia following albuterol. They all get tachycardic, but as best as I can tell, almost none of them are harmed by it.
Yeah, that's what I found as well. I kind of agree with that. So the big question then for me, John, is if we're saying in the ICU, albuterol and steroids are being used primarily to prevent mechanical ventilation or more invasive respiratory support, and then that makes sense, which is why we're not using it on the floor, because as we've said, it doesn't really change length of stay in the data we have at this point. What I foresee happening is a downstream effect of people saying, okay, well, if it could do that, if it could help prevent mechanical ventilation, why not start using it in the ED and all the way through the hospitalization? And that's where I get lost, because I am not sure that makes sense.
Yeah, gosh, I think if you're going to use a drug that probably only works for a subpopulation of the illness you're treating, and your clinical target is an improvement in your assessment of a patient's clinical status, that if you're going to use this drug, and to be very clear, I do use this drug, but if you're going to use this drug, either albuterol or racemic epinephrine, and we haven't really talked too much about corticosteroids today, but assuming you're going to use one of those first two, which we expect to have a readily apparent clinical effect within 30 minutes, the only way it makes sense to use it is to make sure you're using it with a really rigorous eye to an assessment of your patient before and after the drug is given, to see if this patient responds. Because I think most of us would agree clinically that even among patients in whom we have a sneaking suspicion that they actually have some underlying reactive airways disease component, not all of those children get better with albuterol or racemic epinephrine. And there's just not a point to continuing to deliver the drug if you're not seeing a clinical benefit after at least a couple of doses. I think my own personal feelings about this, and again, I want to be clear that this is where I'm departing from the data, because I don't have a randomized control trial of John Pelletier's rational approach to albuterol use in kids with bronchiolitis. But my own personal approach here would be to say, I am using this drug because I believe it is, one, a supportive therapy that should, two, make my patient look better, and three, make my patient look better in a relatively short time frame. So that's a hypothesis that I can test, and I can test it at the bedside. If I'm going to use these drugs for these children, or if I'm going to trial these drugs for these children, except for kids undergoing invasive mechanical ventilation where I can pull numbers off of the vent, my own personal approach is to trial the drug, see if I appreciate a meaningful clinical response. If I do appreciate a meaningful clinical response, to continue to use the drug for that patient. And if I don't appreciate a meaningful clinical response, to stop using the drug for that patient. The only time where I personally might deviate from that approach, if I come back to that same patient 12 hours later And I think to myself, gosh, this patient has really substantially worsened. And now I think I'm really in the context of potentially needing to intubate this patient. Maybe it's worth one more shot at this drug that I don't think worked all that well 12 hours ago, because if it works now, it might really prevent some harm for this patient in front of me. But other than that, I think my own personal approach is to say, gosh, if this didn't work 12 hours ago, I'm not sure there's a point to continue using it. And similarly, when I have a patient who I've been treating with albuterol and steroids or steroids, depending on the context in the ICU, I personally am not offended if the patient has gotten better enough that they are ready to leave the ICU. If the hospitalist says, well, I'm not really sure that there's a point to continuing these therapies in that context. Corticosteroids maybe are a different story, although we didn't really dive into that too much today. And so it's probably best to leave that for its own discussion.
Yeah, that's a big topic as well. We touched on it a bit, but you're right. I would have loved to talk about it more. And to be clear, we're talking, this is a nuanced topic. So in the 15-month-old to 24-month-old, where the huge family history of asthma, where the parents have asthma, the other siblings have asthma, the dog has asthma, everybody has asthma, and the kid has responded in the past to bronchodilators, you're thinking this is probably early onset asthma. We've had a lot of those kids where these viruses will trigger it. But in the kids under 12 months old, that's the population that really struck me as to how much more of steroids and albuterol were being used. And that's why I wanted to have this discussion. So if I'm understanding this right, and I want you to tell me if I'm not, that we are looking at this from an ICU perspective, if I'm looking at this from almost your eyes, this is a patient who's critically ill. There's no higher level of care but the ICU, and that's the highest level of care. And if they're getting worse, especially, the goal is to try to prevent mechanical ventilation, invasive procedures if we can. And therefore, these therapies are being used because they have been shown to at least temporarily improve clinical scores. And the goal at that point is to get the kid well enough not to have to intubate. And that's how I'm seeing it, is that, and there may be a subset that we don't as of yet know and haven't as of yet really elucidated where these therapies will work on. And it may be non-RSV bronchiolitis that it works better on. Who knows? We don't know yet. But as of now, that's how I am understanding our discussion.
Yeah, I don't want to speak for every intensivist in the world, because I think probably if you ask 10 different intensivists about this, you'd get at least 10 slightly different and nuanced opinions on the topic.
And hospitals are no different. We would get the same thing.
I think that's my frame. As I think about this, I have kind of two frames or two categories of patients when I think about using these drugs. Category of patients number one is, truly the run-of-the-mill 4-month-old infant with bronchiolitis. And I'm looking at them and saying, gosh, if I can make this patient look transiently better and avoid intubation, that's a huge clinical benefit for this patient, and also a huge cost savings to the system and a huge stress reduction on the family. Category number two of patients are the ones you mentioned, that 12, 18, gosh, maybe even now 2 or 3-year-old patient, 2 or 3-year-old patient who I think, gosh, I wonder if this is actually early onset asthma. And in those patients, I'm more likely to treat them the way I would a typical asthmatic.
Okay. I agree with that completely. John, I before we get too far, because we're wrapping up, because we're already in over an hour, I do think I would love to bring you back and talk about steroids in this topic. This has been a really good discussion on a topic that I know a lot of hospitalists and ICU doctors would love to get together on. And hopefully we, in a microcosm, have had the conversation that everybody can listen to and kind of understand a bit more.
Yeah, gosh, I'd love to talk with you about steroids in this patient population. And as a teaser, I think, the trial that I think is really worth diving into next time is the trial by Dr. Alan Seri et al. That was published in Pediatrics in 2013 that was really looking at the use of oral dexamethasone in kids who do have a personal atopic history or a strong family history of asthma, like you mentioned. And that trial, specifically wasn't included in the AAP guidelines because that's not the patient population that the guidelines were built to serve.
Interesting. But we'll definitely look at that. Well, we're over an hour in. Is there anything we didn't talk about for what we wanted to discuss that you really want to bring up?
Gosh, the only other things that I just want to say are that I think despite the exhausting clinical workload right now, we are living in truly fascinating epidemiologic times as we look at the transmission of RSV across the country. And I'm really looking forward to talking with folks more about that at PAS this year. I think that the drop off in RSV that we saw in 2020 potentially has a lot to teach us about the epidemiologic links between RSV and asthma. And I hope that we'll be able to tease those out over the next 5 years as these kids grow.
That would be a wonderful addition to what we know about both issues, asthma and RSV. I hope you find this out. I'd love to read about it.
I'll try. It's hard work.
John, I can't tell you how much I appreciate your time and having this discussion. This has been really great. Thank you for coming on.
Thanks so much for having me. It was a real honor.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast. It takes you to a web page. Create a free username and password. Answer some questions that I write that are not hard. And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. Hope you have a great day. We'll see you next time.